Hello and welcome. Today we're diving deep into a complex and critical topic: rejection nephropathy. This condition specifically impacts individuals who have undergone kidney transplantation, and understanding it is vital for improving transplant outcomes. We'll explore what it is, why it happens, how it's diagnosed, and what can be done about it. The primary cause of rejection nephropathy is, quite simply, the recipient's immune system attacking the transplanted kidney. The body recognizes the new kidney as foreign and mounts an immune response intended to eliminate it. This response is mediated by various immune cells, including T cells, B cells, and antibodies. Factors that can increase the risk of rejection include genetic mismatch between the donor and recipient, a history of previous transplants, and non-adherence to immunosuppressant medications. Let's delve into the pathophysiology. Once the immune system recognizes the kidney as foreign, a cascade of events unfolds. T cells infiltrate the kidney tissue, directly damaging the cells. Antibodies bind to the kidney's blood vessels and structures, triggering inflammation and injury. This process leads to swelling, scarring, and eventually, impaired kidney function. Over time, chronic rejection can result in fibrosis, which is the formation of scar tissue and gradual loss of the transplanted kidney's function. The extent and speed of this process vary depending on the type of rejection and the individual's immune response. Pinpointing precise epidemiological data for rejection nephropathy can be challenging because it's often bundled under the broader category of allograft rejection. However, we know that a significant percentage of kidney transplant recipients will experience some form of rejection during their lifetime. The incidence is higher in the initial months after transplantation, but can occur years later as well. Factors like improved immunosuppression regimens are continuously impacting and potentially reducing the overall incidence rates. The signs and symptoms of rejection nephropathy can be subtle and often mimic those of other kidney problems. Some individuals might experience decreased urine output, weight gain due to fluid retention, swelling in the legs, ankles, or face, and elevated blood pressure. Others may have flu-like symptoms such as fever, chills, or fatigue. In some cases, there may be no noticeable symptoms until kidney function is significantly impaired, emphasizing the importance of regular monitoring after transplantation. Diagnosing rejection nephropathy typically involves a combination of blood and urine tests, imaging studies, and a kidney biopsy. Blood tests measure kidney function, such as creatinine and blood urea nitrogen (SBN) levels. Urine tests can detect protein or blood in the urine, indicating kidney damage. Ultrasound or other imaging techniques help visualize the kidney and rule out other causes of dysfunction. However, the gold standard for diagnosis is a kidney biopsy, where a small tissue sample is examined under a microscope to assess for signs of immune-mediated damage. Rejection nephropathy is categorized into different types based on the timing and the mechanisms involved. Acute rejection occurs within the first few months after transplantation and is often mediated by T cells. Chronic rejection develops gradually over months or years and involves a complex interplay of immune cells and antibodies, leading to fibrosis. Antibody-mediated rejection is characterized by the presence of antibodies targeting the donor kidney. Hyperacute rejection happens within minutes to hours of transplantation, but is quite rare due to pre-transplant cross-matching. Identifying the specific type of rejection is critical for guiding treatment strategies. The cornerstone of treatment for rejection nephropathy is immunosuppression. This involves using medications to suppress the immune system and prevent further damage to the transplanted kidney. Common immunosuppressants include corticosteroids, calcineurin inhibitors such as cyclosporine and tacrolimus, EBTOR inhibitors, and antimetabolites. The specific regimen is tailored to the individual and the type of rejection. In cases of antibody-mediated rejection, treatments like plasmapheresis, which removes antibodies from the blood, or intravenous immunoglobulin or VIGA might be used. Adjustments to immunosuppression are often necessary over time to balance the risk of rejection with the risk of infection and other side effects. Unfortunately, preventing rejection nephropathy is not always possible. However, several strategies can minimize the risk. These include careful matching of donor and recipient, ensuring adherence to immunosuppressant medications, and proactively managing other risk factors like high blood pressure and diabetes. Regular monitoring of kidney function and early detection of rejection are also essential for preventing long-term damage. The prognosis for individuals with rejection nephropathy varies depending on the severity and type of rejection, as well as the individual's overall health. Early diagnosis and treatment can often reverse or slow the progression of damage. However, chronic rejection can lead to gradual loss of kidney function and eventually, the need for dialysis or retransplantation. Ongoing research is focused on developing more targeted and effective immunosuppressants, as well as strategies to induce tolerance, where the immune system accepts the transplanted kidney as self. Novel approaches like cellular therapies and gene editing hold promise for the future of transplant medicine, aiming to minimize the need for lifelong immunosuppression and improve long-term outcomes. Thank you for joining us on this exploration of rejection nephropathy.